This lecture will analyze the use of echocardiography during the acute myocardial infarction, mainly for risk detection. Initially, how good is it to detect a myocardial infarction? Several papers in the literature shows that the sensitivity is close to 90%. The presence of a wall motion abnormality has a better sensitivity than an EKG, which may have problem to detect acute myocardial infarction in patients, for instance, with left bundle branch block and in patients with non-elevated ST infarction. Comparing with enzymes, the echo shows the abnormalities much earlier at the onset of the acute myocardial infarction. Basically, what we have to look for are segmental wall motion, contractile abnormalities. Horowitz et al. Have shown that in the first 8 hours of patients admitted for chest pain in an ICU, the echo was abnormal in 100% of patients who had confirmation of an acute transmural myocardial infarction, and 86% of those with non-transmural, like a subendocardial infarction. A patient with normal echo within this period has a high probability not to develop an acute myocardial infarction or any complication during the hospitalization period case developed a subendocardial infarction. Weiser et al. Show that an echocardiogram presents wall motion abnormalities immediately and in all cases of acute transmural infarct. Then a normal contractility of all the walls rules out the presence of an acute transmural infarct. However, it may be associated with subendocardial one. It is important to know that for wall contractility analysis, it is necessary to pay attention not only to the movement of the wall, but to its systolic thickening. A non-contractile wall may move due to tethering of the normal adjacent walls that may pull it toward the left ventricular cavity, but it will not thicken. If there is normal thickening of an infarcted wall, the lesion is less than 20% of the wall width, most of the case in the subendocardial region. Now, prognostic value of echocardiography in patients after a myocardial infarction. The main situations that influence the prognostic of a patient after a established acute myocardial infarction are the presence of obstruction in more than one vessel, the left overall function, and the presence of complications. First, to detect lesion in more than one coronary. Let's say that a patient was admitted with an anterior myocardial infarction and we perform a stress 4 or 5 days later, and it shows that all the non-infarcted wall had enhanced contractility with the stress. Only that non-contractile anterior wall remaining as it was. This situation usually indicates that there is only one coronary obstruction, and it's in the coronary that caused the infarction, the LAD. However, if during the stress a new wall shows contractile abnormalities in a region that does not belong to the infarcted artery, then the patient has more than one vessel disease. Patients with more than one vessel disease has a worse prognosis. Another prognostic important echo sign, even without any stress, is the appearance of another area with contractile abnormality. For instance, if the patient has an inferior acute myocardial infarction with a kinetic inferior wall and normal contracting remaining walls, but suddenly another wall also appears with a contraction abnormality in the initial 30 days after the acute event, the mortality goes up from 14% to 53%, according to Stam et al. Basically, what we are saying here is the higher risk of patients with more than one vessel disease. When we are evaluating the extension of the infarct, we know that the larger the infarct area, the greater the risk. However, if any method for reperfusion was performed, usually there is gradual decrease in the area of infarct seen initially for the next 4 to 5 weeks. Then, we cannot say the initial area will be the final area, since the myocardium may be stunned and will recuperate contraction later on. It is the final area that has prognostic value and indicates the risk for the patient. Another problem is infarct expansion. This expansion is a remodeling of the left ventricle that may occur already on the first days. The infarct area may be only akinetic, and during evolution it becomes dyskinetic. That's a bad sign. It indicates that the infarct is expanding. By expansion, it means that the infarct area will become fibrotic, thin, and locally dilated. This is infarct expansion. There is no larger area of necrosis. This may happen in about 1/3 of the anterior transmural infarcts. The problem is that the area dilates and produces a volume overload of the ventricle with a greater stress over the other normally functioning walls. Then, infarcts of the same size may have different effects on the global functioning of the left ventricle and on the prognosis, depending if there is expansion or not. Different from the expansion is the infarct extension. In the extension, the infarct region had a certain size, but by the second or third day, the infarct area extends. Now the akinetic area is much larger. This is infarct extension with inclusion of adjacent areas. A finding that indicates a better prognostic is when there is a hyperkinesia on the non-infarcted walls, meaning it may be a single vessel coronary obstruction. Another method to evaluate infarct size and hence the prognosis is the microbubbles. When there is an infarct, the capillary bed will be destroyed and the infarcted area will be dark and so will remain after adenosine IV bolus. If there is only a single vessel obstruction, the other walls will get brighter after adenosine. In this case, there is a dark area in the apex, even before adenosine, indicating non-viable myocardium. But after adenosine bolus, this area didn't change much, but the lateral wall became darker, indicating another coronary with obstruction, the circumflex, besides the LAD that caused the infarct. The risk is then much greater.